Good afternoon to all. Thank you for joining us. I welcome you all in 6th Biennial Conference 2022, Indus Hospital and Health Network. I am Dr. Ravi Kumar, Junior Consultant Internal Medicine. Today we have 4 virtual sessions of internal medicine. Each consists of 20 minutes pre-recorded session followed by 10 minutes of live question and answer session. We have 4 topics for discussion today. Topic number 1 is approach to a patient with first episode of seizure. Topic number 2 is antimicrobial resistant. Topic number 3 is approach to a patient with vasculitis and limb gangrene. And topic number 4 is recent update on anticoagulation. If any one of you have any question related to topic, please write down in question and answer section. And there's also an important message for audience. Everyone have to fill feedback form in order to get CME certificate. So it's my pleasure to introduce first speaker of the session, Dr. Dr. Mughees Shirani. He is diplomat, American Board of Psychiatry and Neurology. Currently, he is associate professor and head of department neurology at SIUT Karachi. He also works as consultant neurologist and clinical neurophysiologist at South City Hospital, Karachi. Today, he will be discussing regarding approach to a patient with first episode of seizure.
Dr. Mughees Shirani. I am a consultant neurologist at Sindh Institute of Neurology and Transplantation and South City Hospital. Today, we will be talking about approach to the patient with first seizure. This was a topic given to me. I think this is an important topic. The outline of the talk would be how to differentiate whether what you saw was a seizure and what is the difference between seizure and epilepsy, and then the differential diagnosis, major types of the seizure and importance in the treatment plan, and investigation for the seizures and treatment and pharmacotherapy. So we'll touch base on all these topics. Now, the traditional thinking was that first seizure should not be treated and we should wait for a second seizure before we start the treatment. But now the thought has changed, and we will be talking about the new classification of the seizures and new definition of the epilepsy. So you will see that even with first seizure, sometimes patient should be started on treatment. So what is a seizure? Seizure comes from a Latin word called sacire. So sacire means to possess, and the possession of people used to think about demons, and so this comes from that. But in neurological terms, it is a paroxysmal event due to abnormal, excessive, hypersynchronous discharges from an aggregate of cortical neurons that can manifest in several ways, like loss of consciousness. It could be due to motor or psych or sensory symptoms, or sometimes autonomic phenomena like blood pressure going up and pulse going up. The incidence overall is about 5 to 10% in the world. Some definitions are interesting. In United States, seizure is an epileptic seizure, and in England, this seizure is called a fit. In United States, if you call a seizure a fit, they will think that you are talking about a psychiatric illness. But usually seizure is a clinical manifestation of abnormal, excessive excitation of population of cortical neurons, which are hypersynchronous, as we discussed before. And what is epilepsy? Epilepsy is just if you have 2 seizures which are recurrent and unprovoked, then these are called, the patient would be an epileptic. Causes of seizures are many, and we divide usually seizures into 2, primary or secondary. So if you have a secondary cause, like for example, a brain tumor, that would be secondary epilepsy. And primary, sometimes you do not have the cause or a syndrome, and we'll discuss that in more detail. But basically, it is due to the imbalance between the excitation and inhibitory forces in the central nervous system, and when excitation is more than inhibition, then it will result as seizure. Some of the seizures that can be precipitated are different stresses like psychological, physical stress, sleep deprivation, toxic, and some medications. Notable medications are fluoxetines, for example, ciprofloxacin, moxifloxacin, and levofloxacin, which are being very commonly used right now, can cause and precipitate seizures. Once you see a person with a seizure and it's the first seizure, you need to define whether this is an epileptic seizure or whether it is a non-epileptic event. And that is the most important part. And that takes a this will be defined by good history and a physical examination. And non-epilepsy seizures could be a cardiovascular event, which is very important to make sure that it was not a cardiovascular event that caused a seizure-like episode. Notable are long QT syndromes, Brugada syndromes, which can cause sudden death in younger individuals and can look like seizures. Drug-related, as we talked about, that can precipitate seizures, and drug-related events that can look like seizures but are actually extrapyramidal symptoms, like, for example, with phenothiazines or antiemetic medication. Syncopal events, pre-syncope, syncope, both neurocardiogenic or cardiogenic syncope can look like seizures. Toxic, poisons, infections, and pseudo seizures, pseudo non-epileptic spells can be part of seizures too. So that needs to be decided that they are whether these events were actually seizures or whether these were other events which were not being documented right. Once you have decided that these were seizures and these were multiple, then you call it epilepsy. If it was a single seizure, then you call it an isolated seizure. Still, you have to think about, even with isolated seizure, whether it's an idiopathic seizure or a symptomatic seizure. Symptomatic seizure means that there is a secondary cause that led to that seizure, and we'll discuss that in a little bit more detail in next slides. Non-epileptic seizures can be due to, as we discussed, cardiovascular events, and which are very important to make sure that these are not cardiovascular events. If this was first episode, you have to make sure they are not drug withdrawal effects, toxic, psychiatric illness, or sleep disorders. When you see a person with first seizure, these are the most common things that come to your mind. As we talked about, syncope, vasovagal events are very common, particularly in young girls, that can almost look like seizures. Sometimes they fall, they have few twitching, they can actually lose a little bit of urine control, but usually do not have tongue biting or loss of bowel control. So that can give you an idea that this might be a seizure if they have loss of bowel control or tongue biting, especially on the lateral aspect of the tongue. But syncopal attacks can sometimes produce events that can look like seizures. Psychogenic disorders, alcoholic blackouts or alcohol withdrawal seizures, migraines can sometimes mimic seizure-like episodes but are associated with severe headaches. Transient ischemic attacks like basilar artery transient ischemic attack can cause loss of consciousness and seizure-like episodes. Movement disorders in children, particularly tics and Tourette syndrome, can look like seizures, and there are movements which can almost mimic like seizures, so they have to be differentiated from first episode of a seizure. In young children, breath holding spells, benign positional vertigo, and apnea episodes can be that can look like seizures. Once you have made the diagnosis, then it was an acute event, so you have to make sure whether this is symptomatic or acute symptomatic or unprovoked. And unprovoked seizure can be an isolated, like as we are talking about today, a solitary seizure, and they can be more, then it is called epilepsy. Now, once you define epilepsy, previously it was basically 2 episodes of unprovoked seizures, but as we will discuss, the definition has changed somewhat now, and even 1 episode of seizure can make person diagnosed as epileptic. This is just the epilepsy epidemiology in Pakistan, which is about 1%, very high incidence of epilepsy in Pakistan, and generalized seizures are more common. Now, if you have isolated one seizure, there are causes that can cause seizures, and that needs to be evaluated, including brain injury, head trauma, poisoning, infections, brain trauma like strokes, brain tumor, scar tissue, which is sometimes called scar epilepsy, and that needs to be checked, and that needs to be evaluated. These are the current definition of epilepsy, and in this you will see that the previous definition was two unprovoked or reflex seizures occurring greater than 24 hours apart. So this was very standard. If you have two seizures, it would be called epilepsy. But today we were talking about a single seizure and first seizure. And even one unprovoked seizures and a probability of further seizures similar to general recurrence risk at least 60% after two unprovoked seizures occurring over next 10 years. So this is the definition that has been added recently. And this defines that even one unprovoked seizures that are higher likelihood of seizures in next 10 years would be called an epileptic. We would not go into status epilepticus definition, but first seizure can sometimes present as status epilepticus, and that needs to be treated very aggressively. And then they become epileptics, basically. The first seizure can be as isolated seizure. They can be run of seizures, and that will be then called status epilepticus. Classification is also changed for epilepsy, and if you look, there are epilepsy is now been if you can divide it into three: focal, generalized, and unknown onset. It is important to make sure that you divide these seizures into either focal, generalized, and unknown, because that has great implications in the treatment of epilepsies. For example, focal epilepsies can be treated now very well with epilepsy surgeries, and we will discuss that in a little bit of in future slides too. But if you look at focal seizures, the most common focal seizures with secondary generalizations are called mesiotemporal sclerosis related seizures. So these are focal seizures starting from mesiotemporal lobe of the mesiotemporal lobe and spread, and these are very well treated with surgery. So if you define these seizures very well, the first seizures very well, then we can know that these are coming from temporal lobe. Generalized seizures actually cannot be treated surgically, but have very good medications available. The medications sometimes are different for focal and seizures and generalized seizures. So it is important to differentiate these seizures between focal onset of these seizures or generalized onset. And this can only be achieved by taking a good history and what we call a semiology of the seizure, what happened during the seizures, before seizure, and after the seizure, which is called a post-ictal state. After first seizure, we have to define whether this was one event or there are higher chances that this will become epilepsy or further seizures, and or this was because of a provoked seizure. This was not a provoked seizure. For example, low glucose levels in the blood can cause a seizure, but that would be a provoked seizure. Same thing with alcohol. It would be a provoked seizure. It would not be called epilepsy. So you have to check baseline blood tests, including calcium, magnesium, thyroid tests, urine toxicology, blood alcohol level, and other toxic screen if you think it is toxin related. So to define whether this first seizure was related to any metabolic changes, infections, or drug withdrawals. EEG remains one of the mainstay in the diagnosis of epilepsy syndromes and epilepsy. Earlier you do EEG after the seizure, higher chances for you to pick up abnormalities. Unfortunately, one EEG does not sometimes pick up abnormalities, and you have to repeat EEGs several times before you can pick up abnormalities. EEG also are very specialized tests. They require specialized training of technologists, about 1 or 2 years training of technologists to put the electrodes in the right place and how to do the EEG right. So it has to be in a place, in a setup where the EEG technologist is trained. Then the chances of getting some information from EEG becomes more favorable. Otherwise, if EEG is not done right, there are several artifacts, and there are abnormalities that can be misinterpreted by the EEGer. This is an EEG picture of an Epson seizure. If you look, there is high amplitude spike and wave discharges that look very hypersynchronous, and this is called an Epson seizure. This is very common in children and is very well treated with ethosuximide or valproic acid. Second is neuroimaging in epilepsy. And if you have first isolated seizure, if you have not defined whether it was due to any factor that you have identified, I think every seizure should be every patient with seizure should be subjected to an MRI scan. If you look, MRI is on the second number. It is very good for diagnoses. It can also classify epilepsy for you. It can help in genetics of epilepsy. It can show neurodevelopmental disorder, and it can also help you in differentiating patients who can actually undergo surgery. So there is usually a knee jerk to do a CT scan of head. I think CT scan can help in diagnosis of seizures sometimes, but it would not help you in classification, genetics, neurodevelopment, and surgery. But if you look just in your column, the second column is MRI. Once you have diagnosed seizures and you want more studies, you can do a PET FDG or a SPECT scan or MEG scan that further defines epilepsy. But I think if you find a patient who had one isolated seizure and you think it is a seizure, I think MRI with special cuts for epilepsy and temporal lobe would be a good way to start. This is an MRI that shows hippocampal sclerosis on this side. And if you look, there is widening, and this hippocampus is normal. And this hippocampus on this side, where my arrow is right now, is actually shows atrophy and sclerosis. So this is one that can be surgically treated very easily. Once you have defined seizure and it's an isolated seizure, treatment needs to be decided depending on what we think the course of this isolated seizure would be. If it is first seizure and we have already decided that this patient has higher chances of getting recurrent seizures, you can start the treatment. When you see a person with seizure, there are certain things that can be done as first aid. Patients should be on the ground. They should be turned on one side so they do not aspirate. If they are wearing tight or dupatta, something very very tight, it should be loosened. And then nothing should be placed in their mouth. There's tendency to put spoon or tongue depressor or anything in the mouth. That is very dangerous because it can cause damage to that thing that has been placed in the mouth, and it can be aspirated. So you just have to turn the patient on one side and wait until they wake up. Now, there are a lot of medications available. Fortunately, since 1990s, there are now 25 or 30 medications available for epilepsy and seizures. If you have decided that these are to be treated, then you have to define what kind of seizures these are, and then one of these medications can be chosen. There are first generation medications, second generation medications, and now third generation medications. And some of them are very specific. For example, ethosuximide, it is basically for absence epilepsy. And some medications are more for focal epilepsies with secondary generalization, like for example carbamazepine. But you have to make sure that you understand the basic classification of the seizures before starting the medication, so that if these are generalized epilepsies, the medications are slightly different. For example, valproic acid will work for generalized epilepsies, though carbamazepine would not work for generalized epilepsies. Some medications can make other seizures worse. For example, carbamazepine can make myoclonic seizures worse. So goal of pharmacotherapy is complete control of seizures. When you started, if you've decided with this first seizure that you want to start it, you have to choose a medication that does not have long-term side effects, does not have much drug interactions. And if in children, it can optimize growth and development in pediatric patients and improve quality of life. And so it has to be decided if you are starting after first seizure and you think that the chances of developing next seizures are high, then you look at epilepsy syndrome, for example, JME, juvenile myoclonic epilepsy. First seizure needs to be treated because they will have more seizures. Valproic is a good choice. You have to look at the cost. It should not be very expensive if cost is an issue, and their profile, pharmacokinetic profile. So you have to know what is their absorption, protein binding, distribution, drug-to-drug interaction, whether they are renally excreted or they are hepatic excreted. So this is basically looking at pharmacokinetic issues with anti-epileptics. So you have to know their pharmacokinetics, especially also their side effects, so that when you prescribe these medication, then you know all about their side effects and long-term effects of these medications on the body. In summary, seizure is a common condition. First seizure needs to be differentiated from other phenomena like syncope as described. Type of seizure is important to identify, which depends on careful history and semiology of the seizure. Even one seizure might require lifelong treatment depending on the cause. Careful and thorough testing must be performed to determine the further course of treatment and management, and pharmacotherapy should be carefully selected due to the long-term nature of treatment. Thank you for your time.
Let's move on to question and answer session. If anyone have any question regarding this topic, please write down in question and answer section. Welcome, Dr. Mughees Shirani. We have few questions for you. Question number one is, as we usually see a patient with fevers and seizures in ICU setup, most likely diagnosed with encephalitis. In this case, how long should we continue antiepileptics? Can you hear me, Dr. Mughees Shirani? Can you hear me? Can you hear me, Dr. Mughees Shirani? Can you hear me? म्यूट करूं? Kindly unmute your mic. Can you hear me?
I can hear you very well.
Okay.
I don't know whether you can hear me or not.
Actually, mic.
Let me see. For the technology. Can you hear me now?
So yes. We have few questions. The question number one is like we see a lot of patients with fever and seizures in ICU setup, most likely due to encephalitis or meningoencephalitis. So in these patients, how long should we continue anti-epileptics? And can you hear me? Acha. Kindly remove your headphone and unmute yourself.
Let's see whether you can hear me now. Can you?
Yes. Now
Okay,
I can
perfect.
hear you. I
Okay,
can
perfect.
hear you clearly.
Okay, so I got your first question when you were talking about encephalitis and seizures. So
Yes.
encephalitis means brain infection. So that means
Yes.
that brain has gotten affected. Unfortunately, most of the encephalitis जो होते हैं, they can cause permanent damage to the brain. So persons who have encephalitis and they go on anti-epileptics require long-term treatment. Once we start anti-epileptics, usually you have to continue it for at least 2 years, and then you can decide. But if there is a damage to the brain, the treatment would be lifelong. For example, patients who have herpes encephalitis and then they would have epilepsy, then they would have to take medications all their life. So it will be lifelong medication. Can't hear you. I can't hear you now.
Okay. Second question from
Yes, I
audience
can.
is
Mhm.
what factors need to be considered while taking decision to stop anti-epileptic drug? What
What
factors
factors?
need to be considered while taking decision to stop anti-epileptic drug?
Stop anti-epileptic drugs. Okay.
Yes.
First of all, the anti-epileptic drugs will be stopped only in epilepsies which are controlled for 2 years. So you have to take medications for 2 years. Now, if, as we talked in the lecture, if there are secondary seizures, medications have to be continued lifelong. For example, if it was because of, as we talked about, encephalitis or brain tumor, but if the brain MRI is completely normal, EEG is completely normal after 2 years, then you can decide tapering the medication down and slowly stopping the medications. These usually occur in patients who have genetic epilepsies. Unfortunately, some epilepsies you cannot stop medications even when they are genetic epilepsies. For example, juvenile myoclonic epilepsy. So, if you have diagnosed patient with juvenile myoclonic epilepsy, which is very common epilepsy, which has 3 or 4 kind of seizures, usually the medication has to be taken lifelong. So before deciding to stop the medication, you have to have a normal MRI, normal EEG, no seizures for 2 years, and then you slowly taper the medication down.
Another question from audience is sometimes we get a consult regarding seizures and we find out that there is res creatinine like around between 6 to 7 and urea is around 190 to 200 and we initially start anti-epileptic on the clinical grounds. Then
Mhm.
for how long should we continue anti-epileptic when causes obvious like hypocalcemia, uremia or any other cause, metabolic cause? Then when should we stop once it's just started?
Yes, again, you have to decide if you think that this was because of hyponatremia, for example. Hyponatremia is one of the most common cause of seizures. So if you have decided that it was because of hyponatremia, you can actually stop the medications. You probably should just control the seizures at that time, control hyponatremia, and they don't have to be an anti-epileptic for a very long time. Same with hypercalcemia or hypokalemia or hyperkalemia or any metabolic activity or renal insufficiency. However, if they have a structural problem, like you did an MRI of the brain and you found that there are changes in the brain, and it was probably combination of the fact that they had issues with electrolytes and that they had issues in the brain, then probably the medication will have the same kind of term, like 2 years. So you should just remember 2 years. If you start an anti-epileptic, usually anti-epileptics have to be taken for 2 years before you make the decision to stop them. It doesn't matter the cause, but if it was the cause which was clear, for example, hyponatremia, then you don't even have to treat them with anti-epileptic. You treat the cause, which is hyponatremia. But once you have decided that they are epileptic because of an injury, that they will have recurrent seizures, kidney disease has caused problems in the brain, then they have to be on medications for at least 2 years.
Thank you, Dr. Mughees Shirani. We are grateful for your time and efforts you took to share your thoughts and experience. Thank you so much.
Thank you so much. Thank you.
Okay,
Bye.
now I would like to introduce you with second speaker of the session, Dr. Faisal Mahmood. He is Associate Professor and Head of Department Infectious Disease at Ahon University Hospital, Karachi. He is also Head of Antimicrobial Stewardship Committee at AKUH, Karachi. He has special interest in treatment of multi-drug resistant organism and involved in number of international ground looking at role and evolution of resistance in low to middle socioeconomic countries like Pakistan. He will be discussing today regarding antimicrobial resistance, and I'm glad to announce that this whole session will be live. So welcome, Dr. Faisal Mahmood. You are live now. Can you hear me, Dr. Faisal? Uh, Actually, there is some issue with the internet and some IT issue. Now, I would like to introduce you with third speaker of the session, Dr. David D. Cruz. He is consultant rheumatologist in Louis Coot Lupus Unit at Guy's and St. Thomas Hospital, London. His major clinical and research interests are SLE, antiphospholipid antibody, and systemic vasculitis. He is one of managing editor of journal Lupus and regularly reviewed for major scientific journals. He will be discussing today regarding approach to a patient with vasculitis and limb gangrene.
Biennial conference Beyond the Call of Duty, and thank you very much for the invitation to give this talk on the approach to a patient with vasculitis and limb gangrene. These are my disclosures. So limb and upper digital ischemia is rare, 2 per 100,000 per year from this paper. The most common causes of limb ischemia and gangrene are arterial embolism, localized thrombosis, systemic sclerosis, systemic vasculitis, and iatrogenic disease. For the purposes of this talk, the vasculitic causes comprise around 3% of the total population of limb and ischemia and gangrene, and the causes are listed on the slide here, which are very familiar to this audience: anchor-associated vasculitis, large vessel vasculitis, including Takayasu's and GCA, PAN, cryoglobulins, systemic sclerosis, virus-associated vasculitis, including HIV, Hep C, and COVID-19, Behçet's, and then more recently, checkpoint inhibitors used for the treatment of cancer, such as pembrolizumab and ipilimumab. So I'll just start with lupus. Lupus, as you're well aware, is an autoimmune rheumatic disease with a spectrum of presentations, including mild, moderate, and severe presentations. And the severe presentations do include thrombosis and large vessel vasculitis and gangrene. So cutaneous vasculitis is a driver for limb ischemia and digital ischemia. The prevalence is between around 20 and 30% of patients with lupus, and conventionally, the presence of cutaneous vasculitis is considered a marker of severe disease. So the spectrum of cutaneous vasculitis starts with small vessel vasculitis, consisting of splinter hemorrhages, digital infarcts, palpable purpura, ulcers, and urticarial vasculitis. This is another patient with more severe digital vasculitis. You can see vasculitic lesions on the soles of the feet and ischemic lesions, vasculitic ischemic lesions on the toes of this other patient. Digital ischemia and gangrene, as you can see on this slide, is very uncommon, fortunately. And in this patient, it was vasculitic, because you can see here obvious vasculitic lesion here, but be aware that antiphospholipid syndrome can occur in about 10 to 20% of SLE patients, and that's a differential diagnosis. Very rarely, large vessel vasculitis is seen in lupus with aortitis and dissection, and you will be aware that lupus is associated with accelerated atherosclerosis, and that is obviously a differential diagnosis here. You can see this very extensive dissections here, this lady with aortic disease and lupus. So moving on now to other systemic vascular disease, polyarteritis nodosa is a classic systemic vasculitis. Here's a famous picture from 1866 from Kussmaul and Meyer. And the symptoms of polyarteritis nodosa are usually the patient presents with systemic symptoms, weight loss, fever, severe surgical type abdominal pain, testicular pain, neuropathic symptoms leading on to mononeuritis multiplex, livedo reticularis, calf pain and calf claudication is quite typical, and digital ischemia and digital gangrene and limb gangrene can be a feature of PAN. Hypertension is very common, as is renal impairment. PAN is an ANCA-negative disease. Classically, you can see mesenteric angiograms showing these small aneurysms you can see here, although nowadays CT angiography has superseded these invasive arteriograms and are just as detailed with the quality of CTs nowadays. So what are the associations of polyarteritis nodosa? Well, it's well known that PAN is associated with hepatitis B and less commonly other viruses such as HIV and Hep C, but 10% of PAN patients are Hep B positive. More recently, deficiency of adenosine deaminase 2 or DADA2 has been associated with PAN. So what is DADA2? Deficiency of adenosine deaminase 2 is an autosomal recessive autoinflammatory disease involving systemic vasculitis associated with immunodeficiency and bone marrow failure. This is due to a biallelic loss of function mutations in the ADA2 gene on chromosome 2211q11.1, previously known as CECR1. The systemic vasculitis in DADA2 resembles PAN, hence the relevance to this talk. These patients present with systemic inflammation, autoinflammatory features, livedo reticularis, early onset cerebral infarctions and strokes, renal infarcts, and peripheral vascular disease. So very, very similar indeed to PAN. Diagnosing DADA2, there are no criteria. One has to be aware that this is a possibility and think of this differential diagnosis. You can screen for the diagnosis by looking for low or undetectable plasma ADA2 catalytic activity if you have this available in your laboratory, and you can confirm the diagnosis by molecular genetic analysis, again, needing specialized laboratory. If a patient has confirmed a DADA2, deficiency of adenosine deaminase 2, it is worth considering family screening. So that leads on to this question. If you have patients with PAN, should we be screening all patients for DADA2? It obviously involves cost and laboratory involvement. So this is an important study, quite a large study, comparing 1,100 granulomatosis with polyangiitis and microscopic polyangiitis patients with classic PAN patients. So amongst the GPA-MPA patients, no patients were found to have DADA2 mutations, whereas amongst the PAN patients, 9 of 118, i.e. 7.6%, had the DADA2 mutations. Clinically, they were indistinguishable. The only difference was that the DADA2 PAN patients were about 20 years younger than the ordinary classical PAN patients. Otherwise, they were clinically indistinguishable. Now you could ask, what's the relevance of this? Well, it is relevant because it makes a difference in terms of treatment. So treatment now for DADA2 is anti-TNF therapies, infliximab, adalimumab, and etanercept. So very different from the usual treatment of PAN, which is cyclophosphamide and high doses of steroids. Studies, there are no randomized controlled trials here because of the very small number of patients, but lots of series, and I've given the references on the bottom here. Anti-TNF therapies in DADA2 patients are highly effective in preventing more strokes, normalizing inflammatory markers, and improving PAN-like manifestations. So definitely worth considering DADA2 in your differential diagnosis of polyarteritis nodosa. So the treatment of DADA2 involves anti-TNF therapies, infliximab, adalimumab, and etanercept. There are no clinical trials in this area because of the small number of patients, but several case series have shown that anti-TNF therapies in DADA2 associated PAN is a highly effective treatment. It prevents strokes, normalizes inflammatory markers, and improves polyarteritis nodosa-like manifestations. So moving on to this case of a 57-year-old lady presents in 2019 with painful pallor of the right hand. She reported claudication of the right arm. Whenever she moved her arm or lifted heavy objects, she had pain and pallor in the right arm. She had flitting arthralgia of the hands, wrists, elbows, and shoulders. There's no relevant past history except for a cecal volvulus many years ago. Clinically, she was in pain. The whole right arm was painful. The right hand was pale. She had multiple splinter hemorrhages in the fingernails of the right hand only, and the upper limb pulses on the right were not palpable, and the left upper limb pulses were weak. Audible bruits were heard over the right carotid and over the subclavian arteries. Laboratory studies showed a high ESR and a high CRP, but autoantibodies, including ANCA, ANA, rheumatoid factor, and all lupus serology was negative, including other markers like cryoglobulins. So the Doppler study showed that there was complete occlusion of the right subclavian artery with what looked like thrombus on the scan, and there was a left subclavian artery stenosis. She had a formal angiogram, which you can see here, showed a right subclavian artery aneurysm and a very tight stenosis distal to that aneurysm. She underwent a PET scan, and you can see here that there was uptake in both subclavian arteries. And there were aneurysms on both, in fact, both subclavians, both of which showed FDG uptake. So the diagnosis was that of Takayasu's arteritis. She was treated conventionally with intravenous methylprednisolone, our low-dose urolupus cyclophosphamide regimen, 500 milligrams fortnightly for 6 doses, followed by methotrexate and tocilizumab. And that stenotic area was covered by a saphenous vein bypass graft, and she's done very well. And she's now in remission on methotrexate and tocilizumab. She had angioplasty. She had a graft stenosis, unfortunately, which ruptured when they tried to angioplasty it, and a covered stent was inserted. So there are some vasculitis mimics that we need to consider, and somebody with limb ischemia. And here's a long list of vasculitis mimic that can lead on to digital gangrene: endocarditis, atrial myxoma, cholesterol embolizations, vasospasm. There is an epidemic of cocaine-induced vasculitis in central London, so we do see a bit of this. DIC, TTP, APS, which I'll come on to in a minute, systemic infection, malignancy, and COVID-19 vasculitis and thrombosis. So there is a list of vasculitic mimics. So these are other diseases that can mimic vasculitis, leading on to peripheral ischemia and gangrene. And here's the list of vasculitis mimic: endocarditis, atrial myxoma, cholesterol embolization, cocaine-induced vasospasm. There is an epidemic of cocaine usage in central London, and we do see this reasonably often now. Disseminated intravascular coagulation, TTP, APS I'll come on to, systemic infection, malignancy, and of course, COVID-19 vasculitis and thrombosis. So antiphospholipid syndrome, this audience will be very familiar with this condition, characterized by arterial and venous thrombosis and pregnancy morbidity, including multiple pregnancy losses. The typical laboratory features are lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein 1 antibodies. And if all three of these antibodies are positive, so-called triple positivity, these patients have the highest risk of thrombotic events. Catastrophic antiphospholipid syndrome is fortunately a rare manifestation of antiphospholipid syndrome, less than 1% of antiphospholipid syndrome patients, but it is devastating when it does occur. And here's one of my patients who had very, very severe thrombosis and gangrene. Catastrophic APS is classified with 3 or more organ systems or tissues being affected simultaneously or within a week, these thrombotic events, and confirmation by histopathology of small vessel occlusion and laboratory confirmation of antiphospholipid antibodies. It's not known what triggers catastrophic antiphospholipid syndrome. The vast majority of antiphospholipid syndrome patients do not have CAPS, but these are the factors that are known to precipitate catastrophic APS: surgical procedures, infections, and stopping anticoagulation. Mortality can be between 20 and 50% in this CAPS registry. The current treatment now, there's no trials in this area, but triple therapy is now the treatment of choice for catastrophic antiphospholipid syndrome. Intense anticoagulation, consider thrombosis from thrombolysis for massive thrombosis, plasma exchange, or intravenous immunoglobulins, depending on availability, and low-dose corticosteroids. In patients with lupus and catastrophic APS, one could consider cyclophosphamide. So just to finish with an interesting case, this is a 53-year-old gentleman who works as a window cleaner on that tower in central London. He was perfectly fit and well. He came along last year to have his Oxford AstraZeneca COVID vaccine and no immediate side effects. However, a week later, he had swollen knees, painful ankles, a lower limb rash, calf swelling, but he was otherwise well with no cough or fevers. Previous history of mild asthma. Clinically, he was afebrile, very hypertensive, good oxygen saturations on room air, and he had extensive vasculitic nodules and purpura, which appeared in the preceding few days before admission. He had marked lower limb edema, bilateral knee fusions, and weakness of his hip flexors. So here are the images. You can see obvious vasculitic purpura, necrosis of the skin, vasculitic nodules, and obvious vasculitic lesions here. So all his infection screen was negative. COVID swabs were negative. Inflammation markers surprisingly were low, despite his systemic upset in the vasculitic lesions. Normal renal function, no proteinuria, all antibodies negative, no paraprotein, and the DVT was excluded as the cause of his leg swelling. A skin biopsy showed classic leukocytoclastic vasculitis, affecting small and medium-sized vessels, and there was a secondary paniculitis here. So you can see fibrinoid necrosis here, a neutrophilic infiltrate here, and extravasated red cells. So there's no doubt the diagnosis was that of a systemic vasculitis, and we wanted to understand whether he had large vessel involvement. And so we requested a PET scan, requested an EMG, and we were considering referring him for a muscle biopsy. However, the next morning he became exceedingly unwell, hypotension, tachycardia, and very severe abdominal pain. Clinically, his abdomen was distended. He had a very high CRP and a high white cell count. Shortly afterwards, he had large volume melena. He was found collapsed in the lavatory, and his hemoglobin dropped to 62. He was transfused 2 units, resuscitated with fluids, intravenous pantoprazole, and he was transferred immediately to the intensive therapy unit, where he had an endoscopy. At endoscopy, you can see these clear vasculitic ulcers in the duodenum, and further, you can see this massive clot in the gastric fundus. CT angiography showed the bleeding points here. You can see this is a stomach that's full of blood, and you can see here that the left gastric artery branch was clearly bleeding and leaking contrast. So he underwent an emergency embolization following a CT angiogram. You can see the embolization coils here, which stopped the bleeding, but unfortunately resulted in, as you'd expect, ischemia in the stomach. He carried on bleeding and needed a total of 10 units of blood. And you can see here the dewlifoil lesion. This is an artery peeking up from the gastric mucosa, and this was clipped and stopped bleeding. A CT angiogram, so the question was, did he have polyarteritis nodosa? But a CT angiogram with reconstruction views did not show any microaneurysms. The next day, things got worse. He developed extensive type 1 respiratory failure and bleeding and hemoptysis. A bronchoscopy showed fresh blood, and the CT imaging showed typical changes of diffuse alveolar hemorrhage. So he had clearly almost a microscopic polyangiitis type picture, even though his anchor was negative. He recovered with some treatment, which I'll explain in a minute, but further investigations did not show any vasculitis on his muscle biopsy. He clearly had a vasculitic neuropathy with a left foot drop, and the PET scan, as you can see here, showed pulmonary hemorrhage, but there's no malignancy and there was no large vessel vasculitis. So he was treated with intravenous methylprednisolone, oral prednisolone, our standard urolupus cyclophosphamide regimen, 500 milligrams fortnightly every 2 weeks, and he recovered very quickly indeed. He did have ischemia of his thumb, but that was due to an arterial line on the intensive care unit and not due to his disease. His vasculitic ulcers were improving, and he's now recovered fully. So in summary, here was a gentleman, a very unusual presentation, perfectly fit and well, has the AstraZeneca COVID vaccine, and a week later presents with a severe life-threatening systemic vasculitis with skin disease, gastric ulcers, neuropathy, and diffuse alveolar hemorrhage. And there are other case reports in the literature, both of the COVID vaccine triggering this and COVID itself, COVID infection triggering systemic vasculitis, and that's well recognized. And COVID, as you very well know, is a very thrombotic condition. So there are a number of guidelines coming through now. These are the current American College of Rheumatology guidelines for the management of ANCA-vasculitis, management of polyarteritis nodosa, management of GCA and Takayasu's. And these are very detailed guidelines, and I recommend that you read them. So in summary, systemic vasculitis and digital gangrene and limb ischemia is fortunately rare, but potentially limb and life-threatening. These patients are complicated. They often require critical care admission, and they certainly need multidisciplinary care with renal physicians, vascular surgeons, hematologists, pulmonologists, and early diagnosis and treatment and multidisciplinary care certainly improves outcome. And our gentleman had, fortunately, very good outcome, and he has remained very well since then. So my final slide is acknowledging all my colleagues who have helped me look after these challenging patients. Thank you very much for your attention.
Actually, we were lost in the second session of Dr. Faisal Mahmood due to some internet issue. Now, I would like to invite Dr. Faisal Mahmood to talk about antimicrobial resistance. Dr. Faisal Mahmood, can you hear me? Mahmood, can you hear me? Dr. Faisal Mahmood, can you hear me? So, yes, we can see you, but we can't hear you.
Okay.
Okay. Now we can hear you.
Okay, good. Can you hear me now?
Yes. Yes. Welcome, Dr. Faisal. You are live now. You can proceed for session.
use, and the other is poor infection prevention. Both these come together, and because when they come together, they cause sort of bacteria to become resistant, especially within the hospital. Now, they're both very important. I think infection prevention is probably closer to my heart in many ways because that's what I do as a living for the most part. And this is really everybody's job, doing infection prevention. But when we talk about physicians, the one thing that really is under us is antibiotic use, because we're the ones who decide on using antibiotics dilemma and how this relates to resistance. And then finding the right balance through this dilemma. As residents, I saw there were a lot of residents on the session. So as residents, what are the things you can do to sort of choose the right antibiotic when you have to give an antibiotic? And what are the common mistakes and pitfalls that we've seen in people who, when they prescribed antibiotics? And we're going to finish off by a quick sort of quick talk about why antibiotics fail.
Sorry for inconvenience. Can you turn off your video, Dr. Faisal? Can you turn off your video so that we can see the slides? Mm, mm, okay. Kindly share your slides. Sorry for inconvenience. We can't hear you, Dr. Faisal.
Okay, can you hear me now?
Yes, now I can hear you.
All right, I'll just continue then. I apologize for this. Okay, can you hear me now?
Yes, I can hear you.
Perfect. So I'm not sure where I left off, but I'll just continue where I was to save time. So we know that antibiotics can lead to resistance because getting an antibiotic will increase a person's chance of getting colonized with bug, and you give them low dose antibiotics, and you keep giving this low dose antibiotic, what will happen is that it'll select out, or some bacteria will become more resistant to this, and then become widespread. This is not very common. This happens with Pseudomonas, it happens with TB, but not usually with other bacteria. Other bacteria tend to acquire resistance from elsewhere. What happens more frequently is that if somebody, for example, there's somebody's gut, which has lots of different bacteria, you give them an antibiotic which will wipe out all other bacteria except for infections will be with this resistant organism. What's probably the most common is that once you give an antibiotic, it wipes out all of the bacteria in the gut, and the gut then really is primed to getting colonized with other bacteria, usually from dirty hands, which we haven't cleaned when we've seen other patients, and this then takes over the gut. And in real life, it's probably a mixture of both. When you give an antibiotic to a patient, then some get selected out, some become resistant, and then we introduce more bacteria. And what happens is that the person gets that, if you use it on patient A, it will affect patient B as well. And we know finally that if you give, and this is shown in studies, for example, using carbapenems will increase CRE, using vancomycin will increase VRE rates. And we also know that if you have a CRE Klebsiella, your mortality is higher compared to a sensitive strain. We know that if you have MRSA bacteremia, your mortality is higher compared to MSSA bacteremia, and also general infection. So will die. So how do I find the right balance over here? So really, when you're choosing an antibiotic, you really have to go through 3 steps. The first step is where is the infection, and for this, your history and physical is key. You need to know, is there an infection to begin with? So remember, you want to treat treat the patient, not the lab. You don't treat all cultures. You sort of treat cultures which are relevant. You need to know, is there an urgency to start the antibiotic? Is the patient stable, unstable? Can the patient be monitored? Are there any comorbidities? is beautiful against enterococcus. Another thing is not sending culture. So often we get asked, okay, this patient's going home, what antibiotic to send home on, but no cultures were sent to begin with. So there is no way for us to de-escalate or change. And on the other hand, treating cultures. So, we've had people who came in again with typical UTI, but sputum culture grew Acinetobacter. You can ignore it, right? So don't over-treat cultures, but do remember to send cultures. Giving antibiotics for too long. So sometimes when you give antibiotics for 14 is worsening. Sorry, if somebody gets better, you have cultures, then make sure you de-escalate antibiotics. This idea that patient is getting better, I'm not going to change antibiotics is wrong. And then finally, if somebody's not getting better with the antibiotic, you change. You don't add, you change the antibiotic. So I'm going to stop with this last slide, which is why antibiotics fail. And we know resistant is the only thing we think about, but there are actually 12 or more causes of why somebody would fail therapy. One is the appropriate antibiotic you've got to take into account the necessity, the efficacy, the safety, the cost effectiveness, the acceptability, the follow-up, and the education. So Nescafe, and this slide I stole from Dr. Fareen Ali, which really sums up all of the things that you have to think about when using an antibiotic, which will then reduce your resistance. And I'll end here. I'm really sorry about all of the issues with the internet.
Move on to question and answer session from the audience. So one question from audience is there any role of steroid in septic shock?
Yes, there is a role of steroids in septic shock, especially if somebody, if you suspect relative adrenal insufficiency. But this really comes and goes in and out of fashion. At one point, we were not using it, but now we do use it. So, you have to look at the patient, of course.
Okay. Second question from audience is like we see a lot of patient with Mrsa positive, VRE positive, or MDR Pseudomonas. In these patients, how long should we follow the contact precaution?
So contact precaution needs to be followed for a year, generally is what we say. You can do cultures after, so routine surveillance cultures. And if you have two negatives, so for example, if you're suspecting MRSA or somebody has MRSA and they're colonized, you can do surveillance cultures. And if you have two negative, you can DC isolation. But, in our resource setting, we usually say 1 year is what is the minimum time.
Okay. Any question? So, as we see a lot of multi-drug resistant typhoid patient in our OPDs, and for that, what should we do at community level so that we can improve our antibiogram? Internet problem. Sorry for inconvenience. We can't hear you, Dr. Faisal Mahmood. Actually, we are ending this second session of Dr. Faisal Mahmood due to some internet issue. Thank you, Dr. Faisal Mahmood. Thank you so much for sharing your time and experience with us. If anyone have any question regarding antibiotic resistance, you can write in question and answer section. Now, I would like to move toward the question and answer session of third speaker, Dr. David D. Cruz.
Hello, David Cruz here.
Now let's move on question and answer session of third session, and welcome Dr. David D. Cruz. We have few questions for you. Can you hear me?
Far away. Thanks very much.
Can you hear me?
I can hear you. But you can't hear me.
Yes, now I can hear you. Okay. I have few questions from audience. The question number one is, can we use dogs in antiphospholipid antibody syndrome?
The straight answer is no.
Okay.
So warfarin is the gold standard treatment. So people with thrombotic antiphospholipid syndrome.
Okay. Thank you. Let's move on to next question. What is the role of plasmapheresis in vasculitis, and in which kind of vasculitis we use plasmapheresis?
This question was addressed by the Pexivas trial, the biggest trial in the world in vasculitis, and this clearly showed that plasma exchange did not improve outcome.
Let's move on. Third question from audience. Is there any role of antiplatelet agent in EPLA, antiphospholipid antibody syndrome?
So antiplatelets are used widely in antiphospholipid antibody positive patients, but the evidence does not really support their use.
Okay. Next question is, what will be the dose of steroid as a pulse therapy, 500 or 1 gram?
I tend to use 500 milligram pulses. Generally, the lower the dose, the better in terms of adverse effects. Small studies have shown that they are equivalent. 500 milligrams and 1 gram are equivalent in efficacy, but there are greater side effects with the 1 gram dose of methylprednisolone.
Next question is, as you described in your case, the patient had alveolar hemorrhage and you didn't go for plasmapheresis.
That is correct. So that decision was based on the Bexivas trial, which showed that plasma exchange was not helpful. And indeed, he did very well with cyclophosphamide and corticosteroids.
Okay, thank you, Dr. David D. Cruz. Thanks for such an outstanding presentation.
Okay.
Now I would like to introduce you with last speaker of the session, Dr. Munira Burhani. She is associate professor and consultant hematologist at NIBD Karachi. She is also part of NIBD's bone marrow transplantation team. She was first Pakistani recipient of International Society of Thrombosis and Hemostasis Fellowship in Hemostasis and Thrombosis, and received extensive training at Bianchi and Bonomi Hemophilia and Thrombosis Center, University of Milan, Italy. She will be discussing recent update on anticoagulation.
My name is Dr. Munira Burhani, and I'm working as a medical director and consultant hematologist at National Institute of Blood Disease and Bone Marrow Transplantation Center, Karachi, Pakistan. It's my great honor and pleasure to be a part of ICON 2022. The topic assigned to me is on updates of anticoagulation therapy. I have nothing to disclose. The plan of my today's presentation is I will give you an introduction, the types of anticoagulants present, what are the approved indications of different anticoagulants, what are the pros and cons of anticoagulant therapy, and what anticoagulants and how much dose has to be used in the current COVID era of the anticoagulant treatment, and in the end, the summary and conclusion. So first of all, I want to know what is the thrombosis. What is thrombosis? Thrombosis is the formation of a blood clot inside blood vessels, which obstructs the blood flow in the circulatory system. And the broad classification is the venous thrombosis and arterial thrombosis. And it can develop anywhere in any part of the artery or the vein. And you can see that vein, deep vein thrombosis, the portal vein thrombosis, the renal vein thrombosis, the jugular vein thrombosis, and the arterial thrombosis in the form of thrombotic stroke or myocardial infarction. The venous thromboembolism is a leading cause of death worldwide, and it is a very serious medical condition associated with a significant morbidity and mortality. And for its treatment, different types of anticoagulants are used, such as heparin and vitamin K antagonists, such as warfarin, which has been used for a past many decades until the introduction of a new and novel oral anticoagulants, which are known as NOACs or DOACs. Similarly, over the past several months in the COVID era, there is an increased risk of thromboembolic manifestations associated with the COVID-19. What are the indications of anticoagulation? Its indication depends in a broad range depending on the clinical scenario, which are in the management of venous and the arterial thromboembolism, such as deep vein thrombosis, pulmonary embolism, the treatment of intravascular coagulation, the flushing of lines such as in hemodialysis, cardiopulmonary bypass, or extracorporeal membrane oxygenation. Similarly, anticoagulation can also be used prophylactically in patients with atrial fibrillation, artificial valves, and in the post-operative and critical care settings. What are the targets of different anticoagulant drugs? And the target depends all in the famous the coagulation cascade. We all are very familiar with this coagulation cascade, the intrinsic pathway, extrinsic pathway, and the common pathway. और जितने भी anticoagulant drugs हैं, this inhibits the coagulation factors at different time points to prevent the coagulation cascade. Like in heparin, you see that it inhibits the thrombin, factor 10A, multiple targets को वो inhibit करता है. Vitamin K antagonist की हम जब बात करते हैं तो विटामिन के कोगुलेशन डिपेंडेंट कोगुलेशन फैक्टर्स को वो इनहिबिट करता है, और जो ये डायरेक्ट थ्रोम्बिन इनहिबिटर्स हैं वो डायरेक्ट थ्रोम्बिन को इनहिबिट करते हैं, और फैक्टर 10A इनहिबिटर्स डायरेक्टली फैक्टर 10A को इनहिबिट करते हैं. What is an ideal anticoagulant? जब भी physicians के पास, hematologist के पास patients आते हैं और हमें जब treatment start करती है, always look for an ideal anticoagulant. लेकिन ideal anticoagulant depends on patient, यानी हर patient के लिए हमें selection करने के लिए बहुत जरूरी है, and it varies from patient to patient. हर patient दूसरे patient से मुख्तलिफ है, और patient के साथ आप जब discuss करते हैं कि भाई आपको किस तरह का anticoagulation दिया जाए, कैसी disease है, उसके लिए suitable है या नहीं है, और उसकी compliance इसके साथ होगी या नहीं होगी। तो ये सारे फैक्टर्स होते हैं जिसकी बेसिस पे फिजिशियन जो है अपने पेशेंट के लिए एक आइडियल एंटीकोगुलेंट देखता है। यानी एक बैलेंस चाहिए बिटवीन द एफिकेसी एंड द सेफ्टी। उसके लिए एडमिनिस्ट्रेशन इजी है या नहीं है, ड्रग इंटरैक्शंस तो नहीं है फूड के साथ, उसके साथ दूसरी जो दवाइयां यूज कर रहा है पेशेंट के लिए उसकी डोजिंग कन्वीनियंट है या नहीं है, उसका मैकेनिज्म ऑफ एक्शन कैसा है, फास्ट है, डिलेड है, और उसको बार बार हॉस्पिटल आने की जरूरत तो नहीं है, मॉनिटरिंग की नीड तो नहीं है, और पेशेंट की डोज एडजस्टमेंट्स करने की तो जरूरत नहीं है। ये सारे फैक्टर्स होते हैं जिसके बेसिस के ऊपर हम डिसाइड करते हैं एंटीकोगुलेंट थेरेपी फॉर आवर पेशेंट। डिफरेंट टाइप्स ऑफ एंटीकोगुलेंट्स अवेलेबल है। जैसे मैंने आपसे कहा विटामिन के एंटागोनिस्ट है जो मोस्ट कॉमनली वेरी मच लोग उसके साथ फेमिलियर है, वारफेरिन, और एक जमाने से एक डिकेड से हम इसको वारफेरिन को यूज करते आ रहे हैं, और हमें पता है कि ये विटामिन के जो एंटागोनिस्ट है वो किस तरह मैकेनिज्म ऑफ एक्शन क्या है इनका, कि ये विटामिन के डिपेंडेंट जितने भी कोगुलेशन फैक्टर्स है 2, 7, 9, 10 उनको इनहिबिट कर देते हैं। और रूट ऑफ एडमिनिस्ट्रेशन क्या है, ओरल है। अगर हम हेपरिन की बात करें अनफ्रैक्शनेटेड तो वो इंट्रावेनसली दिया जाता है या सबकुटेनियसली, और वो इनहिबिट किसको करता है, एक्टिविटी ऑफ थ्रोम्बिन को इनहिबिट करता है, लेकिन इसके अलावा एक्टिविटी ऑफ एंटी थ्रोम्बिन 3 को भी इनहिबिट करता है। लो मॉलिक्यूलर वेट हेपरिन जिसको हम मोस्ट कॉमनली यहाँ पे यूज करते हैं एनॉक्सापेरिन के नाम से, वो बाइंड करता है एंटी थ्रोम्बिन के लिए, लेकिन प्राइमरीली उसको इनहिबिट करता है फैक्टर 10A को, एक्टिवेटेड फैक्टर A को इनहिबिट कर देता है। वो सबकुटेनियसली भी यूज हो सकता है, पैरेंटरल फॉर्म में भी यूज हो सकता है। और जो हम नोएक्स और डोएक्स की बात करते हैं उसमें मोस्ट कॉमनली फैक्टर 10A के इनहिबिटर्स आते हैं और डायरेक्ट थ्रोम्बिन इनहिबिटर्स आते हैं, और हम यहाँ पे ज्यादातर जो यूज करते हैं पाकिस्तान में वो फोंडापेरिनॉक्स है और रीवॉक्सिबैन है, एंड नाउ एपिक्सेबैन इज आल्सो अवेलेबल। फोंडापेरिनॉक्स जो है वो सबकुटेनियस है, लेकिन बाकी ओरल फॉर्म्स आर अवेलेबल। लेकिन जो इन थ्रोम्बिन इनहिबिटर्स है लाइक dapigatran is not available in Pakistan, it directly binds to and inhibit the thrombin. प्रॉन्स एंड कॉन्स क्या है डोएक्स के? लोग कहते हैं कि डोएक्स के बहुत सारे फायदे हैं, इजी है, सबसे सब ज्यादा इंपॉर्टेंट ये है कि इसमें नो रूटीन मॉनिटरिंग की नीड नहीं है, पेशेंट को बार बार लेबोरेटरी जाना नहीं पड़ता, पीटीआईआर नहीं देखना पड़ता, फिक्स डोजेस है। ये सारे पॉइंट्स ऐसे हैं जो इसके फेवर में है कि एक तो रैपिड ऑनसेट ऑफ एक्शन है, शॉर्ट हाफ लाइफ है, पेशेंट की कन्वीनियंस बहुत ज्यादा है, क्वालिटी ऑफ लाइफ उसके लिए बहुत ईजी हो जाती है, और कॉस्ट इफेक्टिव इस सेंस में है कि उसके टाइम की बचत है और लेबोरेटरी टेस्टिंग की उसको बार बार जरूरत नहीं पड़ती। ड्रग इंटरैक्शंस नहीं है, फूड इंटरैक्शंस नहीं है, जैसे वॉरफेरिन के साथ हमें प्रॉब्लम्स आती हैं कि हमें देखना होता है कि ग्रीन लीफी वेजिटेबल्स तो नहीं यूज कर रहा पेशेंट, कोई ऐसी मेडिसिन तो नहीं यूज कर रहा जिसकी वजह से वॉरफेरिन या उसके इंटरैक्शंस हो रहे हैं। तो ये सारे पॉजिटिव पॉइंट्स हैं जो डोएक्स के साथ हमें मिलते हैं। अब इंडिकेशंस क्या है डोएक्स की और नोएक्स की? हम सबको पता है कि वेनस थ्रोम्बो एम्बोलिज्म की ट्रीटमेंट में ये सारे आजकल डोएक्स एंड नोएक्स यूज हो रहे हैं, सच एज रिवॉक्सिबैन और एपिक्सेबैन व्हिच आर अवेलेबल इन पाकिस्तान। और अच्छी बात ये है कि आप डायरेक्ट ओरल से स्टार्ट कर सकते हैं, यू डोंट नीड टू ब्रिज विद द पैरेंटल एडमिनिस्ट्रेशन। यहाँ पे हमें पैरेंटल करने की जरूरत नहीं है, एक्सेप्ट डेपिगेट्रन के लिए हमें जरूरत पड़ती है कि वहां पैरेंट्रल हो 5 डेज के लिए। इसी तरह एडॉक्सिबैन में भी पैरेंट्रल है, लेकिन रिवॉक्सिबैन स्टार्ट विद 15 मिलीग्राम बीडी डोज फॉर 3 वीक्स followed by once daily dose. Epixaban जो है 10 milligram for 7 days, Epixaban 10 days for 7 days है, उसके बाद हम 5 milligram BD डोज में देंगे। प्रिवेंशन जो है प्रिवेंशन में भी यूज होता है ये, और प्रिवेंशन में भी हम हिप रिप्लेसमेंट और बाकी सारी चीजों में हम ये यूज करते हैं। डिफरेंट इंडिकेशंस है डोएक्स और नोएक्स की, सच एज डेपिगेट्रन है, रिवॉक्सिबैन है, एपिक्सेबैन है, एंडोक्सिबैन है। ये सिर्फ डिफरेंट इंडिकेशंस में यूज हो रहा है ये, ठीक है। इसके अलावा ये प्रिवेंशन में भी यूज हो रहा है, लाइक रिप्लेसमेंट सर्जरीज, जैसे हिप रिप्लेसमेंट में, नी रिप्लेसमेंट में, प्रोफाइलैक्सिस डोज में ही दिया जाता है। और डोज एडजस्टमेंट्स हमें सिर्फ रीनल फेलियर में, या खास तौर पे जिनके क्रेटिनिन क्लियरेंस लेस देन 30 है, वहां पे डोज या तो रिड्यूस करनी पड़ती है या अवॉइड करनी पड़ती है। सिमिलरली बहुत ज्यादा इनके ड्रग इंटरैक्शंस नहीं है जो हमें नहीं मिलते इस दवाई के साथ। जब भी हम वी स्टार्ट विद द ट्रीटमेंट ऑफ एंटीकोगुलेशन थेरेपी, जब हम पेशेंट से बात करते हैं, वी ऑलवेज सी कि वेदर दिस थ्रोम्बोसिस का जो इवेंट है वो प्रोवोक्ड है या अनप्रोवोक्ड है, क्योंकि ये हमें हेल्प करता है डिसाइड करने में कि कितने ड्यूरेशन तक इनको एंटीकोगुलेशन थेरेपी नीडेड है, वेदर इट्स फॉर 3 months, 6 months, एक्सटेंडेड पीरियड के लिए देनी है या इनडेफिनेट पीरियड के लिए देनी है। और प्रोवोक का मतलब ये है कि ट्रांजिट रिस्क फैक्टर्स मौजूद है, सच एज सर्जरी है, कोई ट्रॉमा है, कोई लेग इंजरी है, इमोबिलाइजेशन है, जिसके बेसिस के ऊपर हम कहते हैं कि ये प्रोवोक्ड थ्रोम्बोएम्बोलिज्म हुआ है। और जहां पे रिस्क फैक्टर्स कोई भी नहीं मिलते हमें, तो हम उसको कहते हैं अनप्रोवोक्ड, और ऑल्सो टर्म एज इडियोपैथिक, यानी पेशेंट के अंदर कोई रिस्क फैक्टर्स नहीं है, लाइक कैंसर, थ्रोम्बोफीलिया, कोई हिस्ट्री नहीं है, फैमिली हिस्ट्री और इस तरह की कोई भी चीज। अच्छा, अब ड्यूरेशन ऑफ एंटीकोगुलेशन, जैसे मैंने आपसे कहा, डिपेंड्स ऑन प्रोवोक्ड और वर्सेस अनप्रोवोक्ड। आप जितनी भी गाइडलाइंस देखें, अमेरिकन सोसाइटी देख लें, चेस की गाइडलाइंस देख लें, नाइस की गाइडलाइंस देख लें, थ्रोम्बोसिस कनाडा की गाइडलाइंस देखें, सब में जो प्रोवोक्ड है फॉर 3 months और उससे ज्यादा नहीं यूजुअली दिया जाता, और जो अनप्रोवोक्ड है वहां पे मिनिमम 3 months है एंड वेरी टू 6 months। लेकिन जहां पे सेकंड अनप्रोवोक्ड इवेंट है या कोई और चीज है, तो फिर हम इनडेफिनेट की तरफ जाते हैं। लेकिन जब भी हम इनडेफिनेट की बात करते हैं तो हमें रिस्क ऑफ ब्लीडिंग जरूर देखने की जरूरत होती है कि वहां रिस्क ऑफ ब्लीडिंग कितना है। अगर रिस्क ऑफ ब्लीडिंग है तो फिर हम वहां पे टेपर डाउन करते हैं डोज ऑफ एंटीकोगुलेशन थेरेपी। जब एंटीकोगुलेंट थेरेपी फॉर स्प्लेटनिक वेन थ्रोम्बोसिस की बात आती है, स्पेशली इन सिरोटिक पेशेंट्स जो है, सिरोटिक पेशेंट्स में हम लो मॉलिक्यूलर वेट हेपरिन यूज करते हैं, और फिर हम वी कैन स्विच टू विटामिन के एंटागोनिस्ट और डोवैक्स डिपेंडिंग ऑन द सीवियरिटी ऑफ द लिवर डिसफंक्शन। स्पेशली हमें वहां पे वेरिसियल ब्लीडिंग का ख्याल रखना पड़ता है, और यूजुअली द ड्यूरेशन इज फॉर 3 to 6 months एंड वी इवेलुएट कंटिन्यूसली आवर पेशेंट फॉर द ब्लीडिंग रिस्क। और अगर कैंसर पेशेंट्स की बात करें, इनिशियल मैनेजमेंट एंड प्राइमरी जो ट्रीटमेंट होता है, इट्स विद द लो मॉलिक्यूलर वेट हेपरिन, और यहाँ पे भी अब डोवैक्स का रोल आ गया है, डोवैक्स आर अलाउड। The first choice is low molecular weight heparin, especially in the risk of bleeding, जहाँ पे specially GI cancers है, genitourinary cancers है, वहाँ पे हम low molecular weight heparin ही first choice है, and duration is 3 to 6 months, and we may be considered indefinitely जब तक कैंसर मौजूद है। स्विचिंग, जब हम पेशेंट्स को एंटीकोगुलेंट थेरेपी देते हैं तब भी ये बात हो रही होती है कि स्विचिंग अलाउड है या नहीं अलाउड है। यस, स्विचिंग इज अलाउड, और आप दोनों तरीके से स्विचिंग कर सकते हैं, यानी डोएक्स से वारफेरिन की तरफ भी कर सकते हैं और वारफेरिन से डोएक्स भी कर सकते हैं, यानी इन वाइस वर्सा इज अवेलेबल। और जनरल यूजुअली ये होता है कि जब भी INR इज अराउंड 2.5 और या लेस देन 2 हो तो आप वारफेरिन से स्विच कर सकते हैं डोएक की तरफ। इसी तरह लोग हमसे पूछते हैं कि हम डोएक से वारफेरिन पे भी स्विच कर सकते हैं। यस, इट कैन बी स्विच, और वहां पे भी यही है कि INR अराउंड 2 होना चाहिए, और जब भी नेक्स्ट डोज होगा डोएक्स का, उसी वक्त आप वारफेरिन स्टार्ट कर देंगे। प्रोसीजर ब्लीडिंग रिस्क हमेशा होता है, और स्पेशली जब हमारे पेशेंट्स कोई भी एंटीकोगुलेशन थेरेपी लेते हैं, वहां हमें पता है कि वहां ब्लीडिंग का रिस्क हो सकता है, और आपने ये देखना है कि ब्लीडिंग का रिस्क कितना है ड्यूरिंग द एंटीकोगुलेशन थेरेपी। आप ब्लीडिंग जब रिस्क मिनिमल हो तो वहां पे इंटरप्शन की जरूरत नहीं होती एंटीकोगुलेंट थेरेपी की। जहां ब्लीडिंग रिस्क लो हो तो वहां आप टेम्परेरी एंटीकोगुलेंट थेरेपी को होल्ड करते हैं, और जहां पे ब्लीडिंग रिस्क ज्यादा होगा वहां इंटरप्शन करने की जरूरत है फॉर द जब भी जो प्रोसीजर हो जाए देन वी स्टार्ट विद द एंटीकोगुलेशन थेरेपी एज सून एज के पेशेंट का हीमोस्टेसिस अचीव हो गया, पेशेंट स्टेबल है और ब्लीडिंग नहीं होगी। सिमिलरली जब हम नोएक्स यूज कर रहे होते हैं और पेशेंट की क्रिएटिनिन क्लियरेंस खास तौर पे बहुत इंपॉर्टेंट होती है, उसकी मॉनिटरिंग इंपॉर्टेंट है बेसलाइन पे और फिर 3 मंथ्स पे, और हम देखते हैं कि पेशेंट को कहीं रीनल इम्पेयरमेंट तो नहीं है। अगर रीनल इम्पेयरमेंट है तो वी रिड्यूस द डोज, और लिटरेचर हमें ये बताता है कि रीरोक्सिबैन के ट्रायल्स अवेलेबल है जिसमें उन्होंने यूज किया है रीनल पेशेंट्स के ऊपर 15 मिलीग्राम ओडी डोज पे, और ये इतने सारे पेशेंट्स पे ये ट्रायल हुआ है। और नोवैक्स कैन बी यूज्ड in a renal failure patients with a low dose, especially if the creatinine clearance is around 30. Similarly, जब हम कैंसर पेशेंट्स की बात करते हैं और वहां पे हम गाइडलाइंस को रिव्यू करते हैं, तो ISTH की जितनी भी गाइडलाइंस है 2018 की